Respected guests, professors, senior consultants, esteemed faculty members, and fellow colleagues. We may now commence our day 4 of the IRC RCOG Summit. I am Dr. Melissa Maskuri, a fellow in urogynecology at Shalimar Hospital, Lahore, and it is my pleasure to be moderating today's urogynecology session, a field that continues to evolve rapidly and plays a vital role in improving quality of life of the woman. We kindly request all our esteemed expert panelists to take their seats on the stage at the commencement of the session. Respectfully, Professor Farooq Zaman, Professor Ruqayya Sultana, Dr. Uruj Kashif, and Professor Shamila Ijaz Munir. All poster assessors are also requested to be seated in front at the reserved seats and proceed to the poster arena at sharp 12 p.m., while poster presenters are requested to be beside the posters to facilitate the discussion and evaluation at 11:50 a.m. sharp. In the interest of maintaining the scheduled time, I would like to remind all presenters to adhere strictly to the allocated time of 10 minutes. A first bell will be rung at 8 minutes to help you conclude your presentation, and the display will automatically discontinue at the final bell at 10 minutes. Also, another kind reminder, please use the hind door while entry and exit once the session starts, and please keep your mobile phones silent. To begin the session, I would request our first speaker, Dr. Aisha Ismail. She is a fellow in urogynecology at Ayub Teaching Hospital, Aptabad, with her talk on urinary incontinence in antenatal women and its impact on the quality of life.
Assalamu alaikum, respected colleagues and distinguished faculty. It's a privilege for me today to present in this international conference. I am Dr. Aisha Ismail, PG Urogynecology, joined by my supervisor and co-author, Professor Dr. Ruqayya Sultana from Ayub Teaching Hospital, Abbottabad. The topic of today's presentation is urinary incontinence in antenatal women and its impact on quality of life. Urinary incontinence is the involuntary leakage of urine, and it is common during pregnancy due to hormonal and anatomical changes. However, it is often underreported because women feel embarrassed or consider it a normal finding of pregnancy. It affects the physical health, emotional well-being, and social life. Many pregnant women experience urinary symptoms, but there is a lack of awareness and screening, so it leads to reduced quality of life. Hence, we felt the need to assess prevalence, severity, and impact on daily activities and health-related quality of life. The primary objectives of our study were to determine prevalence of urinary incontinence, to assess severity of incontinence in antenatal women, and to identify associated demographic and clinical risk factors. While the secondary objectives were to evaluate impact of incontinence on health-related quality of life and to measure bother and impact on daily activities. It was a cross-sectional prospective study, and the inclusion criteria were age greater than or equal to 20 years, singleton pregnancy, and gestational age greater than 37 weeks, while the exclusion criteria were congenital urogenital disorders, chronic diseases, and pelvic trauma or complications. A total of 388 pregnant women were enrolled, and there was sequential sampling in our study. Data was collected by validated standardized questionnaires, including International Consultation on Incontinence Questionnaire, Urinary Incontinence Short Form, Urinary Distress Inventory, International Incontinence Questionnaire 7, and Health Survey. Study was conducted after approval from Ethical Review Committee of our institute. Informed consent was taken from all patients. Confidentiality was maintained throughout the study, and participants were allowed to withdraw any time during the study. Data was analyzed using SPSS software and chi-square test was used in which p-value was set at less than 0.05. Now let's come to the most important part of the study, which is the results. 70.1% of the patients had frequent urination, 51% had urinary incontinence, 42.8% had leakage when coughing or sneezing, and 37.9% of patients had small drops leakage. 55.4% of the patients had household work impaired due to urinary incontinence, 48.5% had physical activities impairment, 44.8% had emotional health impairment, and 32.5% patients had social activities impairment due to this complaint. 17% of the patients leaked just once a day, while 15.5% leaked occasionally. 14.2% were not bothered, 38.1% were slightly bothered, 32.5% were moderately bothered, and 15.2% patients were greatly bothered by this complaint. 87% of the patients coughed or sneezed and it was a trigger for their urinary incontinence. And like I told you, 17% leaked once a day and 15.5% leaked occasionally. 10.1% patients also leaked during sleep. In our study, we found out that symptom severity and daily impact was significant as p-value was less than 0.001, while age and volume had no significant association with urinary incontinence. To conclude, urinary incontinence is common in late pregnancy and it is not a trivial problem. It significantly reduces quality of life, affects physical tasks, emotional well-being, and general health of the patients. Because many women experience mild to moderate symptoms, they may underreport or accept this as a normal finding of pregnancy. So our research emphasizes the necessity for early screening, patient education, and pelvic floor health integration into antenatal care to improve maternal well-being and possibly to reduce postpartum complications. Thank you.
Thank you very much, Dr. Aisha. Our second speaker, Dr. Nazish Baloch, consultant urogynecologist at Arya Institute of Medical Science, Quetta, will present a qualitative analysis on the impact of urinary incontinence on the quality of life of women in Pakistan.
Assalamu alaikum and good morning, everyone. So, title of my study is Impact of Urinary Incontinence on Quality of Life of Women in Pakistan, a Qualitative Analysis. So, urinary incontinence is defined by International Continence Society as involuntary leakage of urine. It's highly prevalent yet significantly underreported condition, especially in underdeveloped countries like Pakistan. So the overall prevalence reported is around 25 to 45%. However, the prevalence reported in Pakistan is around 31%. So what was the rationale for conducting this study? As we know that urinary incontinence has a significant effect on women's daily life functioning and overall quality of life. There are various assessment tools and questionnaires that have been developed to evaluate the severity and impact on the quality of life. However, most of the assessment tools and questionnaires were developed in the Western countries. So they overlook the cultural and religious aspect that holds essential value in the Muslim communities. So this creates a gap in capturing the quality of life of impact for the women from different cultural and religious background. Study design and methodology. So this was a qualitative study which was conducted at Khan University Hospital from October 2024 till March 2025. We recruited women aged 18 years or more who presented to us with urinary incontinence and are able to communicate effectively in Urdu. So total 15 audio recorded interviews were conducted and allowing the participants to share their experiences in detail. Data analysis. For data analysis, we use an inductive qualitative content analysis approach. Initially, all the interview transcripts were read multiple times and then open coding were performed. After open coding, themes and sub-themes were created. So these are the results of our study. Total of 6 main themes were emerged with subsequent sub-themes, including impact on daily life activities, impact on social and interpersonal relationship, barriers to the effective healthcare engagement, impairment in the religious activities, psychological impact, and self-adoptive coping strategies. So the first theme was impact on the daily life activities. So this theme highlights that urinary incontinence is significantly affecting the woman's daily life functioning. Almost all of the participants reported restricted mobility out of the fear of the urinary leak, and along with that they also reported that they have inability to perform their household chores and child caring responsibilities. They also face challenges in their work-life balance because of the frequent visits to the washroom, and they reported that their work efficacy and proficiency was also affected because of this condition. Second was impairment in the religious activities. So this was the most unique and significant theme emerged in our study, reflecting an aspect that was not previously discussed in the existing literature. So as we know that religious activities require ritual purity, so because most of the participants reported that they were unable to maintain the ritual purity, and because of that they have a noticeable decline in their religious activities. And because they were unable to perform their religious obligations, so they have the internal guilt. Along with that, they ultimately lead to the inner religious conflict. Third was impact on the social and interpersonal relationship. Patients also reported social withdrawal and social isolation because of this underlying condition. They also have intimacy problem. Because of that, they have relationship strains along with their partners. So they also reported psychological impact, including frustration, social anxiety, emotional distress, and that ultimately leads to the self-stigmatization and low self-esteem and lower confidence. Self-adopting coping strategies. So this theme highlights the self-adopting coping strategies of the participant. Most of the participants adopted social disengagement, and many of the participants reported decrease in the fluid intake, and they also have limited their religious activities because of the frequent urinary leaks. So this was the last sub-theme, barrier to the effective healthcare engagement. So most of the participants were reluctant to seek medical care because of the embarrassment, and most of them believe that probably that's the normal part of aging and pregnancy. So that misconception ultimately leads to the delay in their reluctance, delay in the seek to medical assistance. And many of them also reported that their condition was oversighted or underdiagnosed. So with our study, we conclude that urinary incontinence has negative impact on a woman's physical, psychological, social, as well as spiritual well-being. Religious impact emerges as a distinct and culturally significant theme. So participants find it difficult to maintain ritual purities during Islamic practices, and that ultimately lead to decline in the religious activities and finally leads to the internal religious conflict. So future recommendations include train healthcare professionals to effectively screen, actively identify and manage the cases of urinary incontinence, educational programs for general population to address myths and misconception of urinary incontinence, and development of culturally sensitive assessment tool integrating religious and spiritual aspects. Thank you.
Thank you. I would like to warmly welcome Professor Tayyaba Waseem as an expert panelist on the stage. Our next speaker, Dr. Shima Yusuf, a dedicated clinical fellow urogynecologist, will present her research as a comparison between two drugs, the better choice for lower urinary tract infection.
Assalamu alaikum everyone. I'm Dr. Shima Yusuf. I'm currently working as Senior Registrar at Lady HSN Hospital. So today I'm going to present my research study on nitrofurantoin or fosfomycin, the better choice for lower urinary tract infection. Almost 50 to 60% of women have at least one episode of urinary tract infection during their lifetime. And greater than 70% of E. coli is resistant to ceftriaxone and ciprofloxacin in Pakistan, which are the most commonly used drugs to treat urinary tract infection currently in our country. However, according to the guidelines, the first-line agents are nitrofurantoin and fosfomycin. Despite being first lines, they are not used very sparingly for treating urinary tract infections. And data comparing their real-world effectiveness remain limited, particularly in local clinical settings. My study aims to compare the efficacy of both drugs for optimal patient outcomes. It was a quasi-experimental study performed in urogynecology department of Shalimar Hospital, Lahore, during 4th September 2024 to 4th March 2025. Total of 392 female 15 to 49 years of age were included in this study. Inclusion criteria of the study included patients presenting with one of the following symptoms, which are dysuria, urinary urgency, increased urinary frequency, suprapubic discomfort, and positive nitrites or leukocyte esterase on dipstick test, or 3 or more than 3 leukocytes per high power field on urine microscopy. The exclusion criteria included pregnancy or breastfeeding women, patients with signs of upper urinary tract infection such as fever, chills, flank pain, those having recent antibiotic use within 4 weeks, catheterized patients, immunocompromised individuals, and those having poor kidney function. After enrollment, baseline urine culture samples were collected for culture and sensitivity from all patients. However, we started empirical treatment prior to the culture report. Half of the patients, a total of 196, were given nitrofurantoin 100 milligrams twice daily for 5 days and categorized as group A. And the other half, labeled as group B, received 3 grams of oral fosfomycin as a single dose. The main outcome measures were the patient clinical improvement on the 7th day after completing of antibiotic, and secondary outcome measures included bacteriological response at day 14 after therapy completion, adverse drug reactions, and quality of life. Patient-centered outcomes were assessed using a 0 to 10 Likert scale for ease of antibiotic use, impact on daily functioning, severity of side effects, and post-treatment quality of life. If we come to the results, the demographic data was comparable between the two groups. The most commonly isolated uropathogen was E. coli, followed by Enterococcus, Klebsiella, Staphylococcus, and Proteus was the least common micropathogen isolated. Total 6 patients had E. coli UTI, which was resistant to nitrofurantoin, while no resistance shown to fosfomycin, which can be likely because it is underused in our country. Symptoms of urinary tract infection was comparable between the two groups. The most common symptoms in both groups included increased urinary frequency, followed by dysuria, suprapubic tenderness, and least common symptom was urinary urgency. Clinical and microbiological resolution was significantly greater with nitrofurantoin compared with fosfomycin. If you look at this chart, almost 82% of patients receiving nitrofurantoin were clinically asymptomatic at 7th day after completing the therapy as compared to fosfomycin, which is 71%. And 91% of patients who received nitrofurantoin had no micropathogen on urine culture report on 14th day of therapy as compared to 84% in fosfomycin group. Adverse effects including gastrointestinal symptoms such as nausea, diarrhea, and abdominal discomfort were reported more frequently in fosfomycin group as compared to the nitrofurantoin. Most common adverse effect was diarrhea, which was reported in 25 patients taking fosfomycin as compared to 12 patients taking nitrofurantoin, which was statistically significant. If we look into this chart, this shows the adverse effects which occurred between the two groups, and the most common adverse effects being diarrhea, which is 12.7% of patients in fosfomycin group as compared to 6.1%. Other side effects were comparable between the two groups. Patient-centered outcome was assessed by evaluating the clinical recovery, symptom relief, patient satisfaction, and quality of life in the patients. Although fosfomycin was rated easier to use, nitrofurantoin resulted in greater patient satisfaction, fewer side effects, and better post-quality treatment quality of life. If we look into this chart, this shows symptom resolution at 7 days after antibiotic therapy was more rapid in those patients receiving nitrofurantoin as compared to those who received single dose of fosfomycin. And patient satisfaction and quality of life was also more significant in nitrofurantoin group. Ease of antibiotic, if you look at that, patient reported that fosfomycin was easier to use as compared to nitrofurantoin. However, almost 89% of patients responded willingness to reuse nitrofurantoin as compared to 78% in the fosfomycin group, particularly to the side effects which occurred, severity of the side effects which occurred with the fosfomycin. So conclusion, fosfomycin and nitrofurantoin have been identified as the preferred treatment options for lower urinary tract infection in outpatients. A greater proportion of patients receiving nitrofurantoin achieved clinical recovery, reflecting superior symptomatic improvement and a higher microbiological eradication, indicating more efficient bacterial clearance on the follow-up urine cultures. Fosfomycin remains a useful alternative, particularly for those with poor compliance or intolerant to multi-dose antibiotic regimes. Thank you so much. That's the end.
Thank you, Dr. Sheema. For the next talk, I would like to invite Professor Ruqayya Sultana, a prominent urogynecologist at Ayub Teaching Hospital, Aptabad, for her talk on BMI age and parity as predictors of complications after birth colpus suspension. Please.
Thank you, Vanessa. Bismillahirrahmanirrahim. Assalamu alaikum, everyone. First of all, I would like to congratulate Professor Nazli for successfully heading towards the end of the conference despite all the odds being created by the geopolitical situation in the country and the region. And also, I'm extremely happy, and it's worth mentioning, the way the RCOG team has been appreciating your work throughout the conference, and especially in the presidential address yesterday. It's really commendable, and we really feel you like a pride of Pakistan. And among your team, I think Rabia, that also needs a big applause. So now coming towards my topic, which is the age, BMI, and parity as predictors of complication after birth colpus suspension. The background being that birth colpus suspension, we all know, is one of the retropubic procedure for stress urinary incontinence. The overall morbidity of the procedure is low, but if the specific factors like BMI, increased BMI, age, and parity, they come into play, it can influence the surgical difficulty. Previous studies show mixed results. Obesity may increase operative time, but not major adverse events. High parity and age are linked to pelvic floor weakness and friable tissues. Factors predicting complications remain under studies. The objective of my study are to explore the association between age, BMI, and parity with intraoperative and early postoperative complications, to evaluate surgical outcomes in terms of the operating time, blood loss, and tissue findings in a retrospective cohort of 11 patients. Although that number of patients seems less, but this is a true data which what we operated in the last year. The literature search showed that large trials indicate that operating time and blood loss, rather than patient demographics alone, they are main predictors of complication. But a study by Roger in 2006 found that the obese women, they require a longer time as compared to the patients who have low BMI. Age and parity, they are recognized risk factors for pelvic floor weakness and potentially friable tissues during dissection. So BMI and age were not independently associated with post-surgical complication in his study. So a gap exists, and I tried to fill that gap through a study which was conducted in Ayub Teaching Hospital, which is in the last 1 year, from January 1st to December 31st, 2025. The sample size included a cohort of 11 women, and the data which was recorded in the initial notes at the time of admission were age, BMI, and the parity of each patient. The intraoperative findings which are recorded were the operative time, estimated blood loss, and the tissue findings, whether they were healthy, fragile, or they were tearing at the time of surgery. Post-operative complications, they were measured for a period of 6 months. So the time period, it's only 6 months, although for the long-term complications, the time should be more than that. Then the data, it was analyzed on SPSS 25, descriptive statistics, Spearman correlations, Fisher exact tests were utilized for exploratory analysis. The patients, those patients were included who had undergone Bush-Colpus suspension either as a primary procedure or as a secondary procedure after the initial procedure has failed. And in our sample, only one patient was with secondary treatment as Bush-Colpus suspension. The patients who were excluded, those who had incomplete demographic data or those who were lost to follow-up prior to the minimal threshold of analysis. And the ethical approval for the study was taken from the ethical committee of the Ayub Teaching Hospital. So this was the preoperative variables as already described, and the intraop matrix of blood loss as well as the tissue finding, plus any damage to the bladder or the ureter that was noted, and post-operatively the patients were followed for a period of 6 months for any complication. The mean age of the patient was 58 years, ranging from 45 to 70, and the mean BMI was 32, ranging from 25 to 39. And they were categorized into two, those who had a BMI of more than 30 or they had a BMI of less than 30. The parity ranged from 0 to 5 and the average was taken as 3. That is, less than 3 had less complications and more than 3 had more complications. It was noted that the patients who had a BMI of more than 30, the mean incremental time was 25 minutes more as compared to the patients who had a BMI of less than 30. Direct surgical observation noted limited visibility and high difficult dissection in the obese cases, directly contributing to the extended operating time without increasing serious complications. So this is a graphical representation of the BMI on the results. Now it has been seen that, as already mentioned, that patients who had a parity of less than 3, the tissue integrity gradient was good, and 1 in 7 patients exhibited mucosal tearing. As compared to the patients who had parity of 4 or more, the tissue tearing was 3 out of 4. And high parity demonstrated a direct observational correlation with compromised pelvic tissue integrity, increasing intraoperative tissue fragility. As compared to the data, which was the literature review, what we found in our study that age was an independent variable. And unlike parity and BMI, advanced age showed no clear isolated effect on the surgical outcomes or intraoperative friction within the cohort. Luckily, the patients intraoperative, there was no major blood loss, and the patients who were obese with BMI of more than 30, It was difficult to perform the dissection. To maintain the hemostasis was difficult, and the tissue especially the paravaginal fascia, it was difficult to identify. And post-operatively, only one of the patient had voiding difficulty, and she needed to be catheterized for a period of 2 weeks. And after that, her residual was less than 100. There was no case of reoperation because of hemorrhage or because of the failure of the procedure, and there was also no other major complication as a result of the damage to the bladder or the ureteric ligation. So our findings echo Rogers' findings confirming that obesity prolongs operative time. In our case, it was 25 minutes more, while in his study it was only 15 minutes more. And the direct correlation between high parity and tissue fragility supports the established understanding of parity-induced pelvic floor weakness, which occurs with the successive pregnancies leading to denervation and tearing of the tissues. Voiding dysfunction, only one patient. Study power with a sample size of only 11. These findings represent important descriptive trends rather than statistically significant powered conclusions. So severe complications after Birch-Colpus suspension were rare in our series because the post-operative time was less, only 6 months. Although in other series we have seen occult urge incontinence occurring and also the prolapse, because it requires a longer time for follow-up, which was not in our case. So what implementations or what lessons needed to be learned from these is that there should be a proactive counseling of these patients with high BMI, explaining them that the more time will be taken and they should expect more post-operative complications in terms of wound infections. Or during the surgery, the strategic dissection should be performed to anticipate, because we anticipate restricted visibility and challenging the retrospubic dissection. And optimized light as well as the retraction tools should be used to overcome this problem. And also we should learn that in high parity patients, we should be prepared for fragility of the tissues and utilize delicate handling of the tissues technique and optimize suturing placement to accommodate atrophic mucosa. Because at least half of the tissue from the paravaginal fascia need to be taken for the successful outcome of the surgery. Limitations, as already explained, that the sample size was less. It was underpowered for formal statistical significance, and the follow-up was for only 6 months. So these are some. The future research, larger studies are needed to confirm if BMI, age or parity are independent predictors of complication. These are some of the pictures of the procedure Birch-Colpus suspension being performed in our unit. The phalansteal incision has been given. The patient is placed in supine position with abducted legs so that the assistant can handle the tissues from the vagina to expose the paravaginal tissue, and as you can see here, you can see the bulge, which is because where the tissue sutures are being placed, that the assistant is pushing the paravaginal fascia with the finger placed in the vagina so that the suture placement can be easier. Post-operatively, cystoscopy was performed so that we can confirm the urine, jet of the urine coming out of the ureteric orifices, and that is, there is no trauma to the bladder mucosa, and none of the sutures has crossed the bladder mucosa, so that if there is any, it can be immediately removed. So this is the summary of my study. The take-home message is that for improved results, surgeons should emphasize careful preoperative assessment, thorough patient counseling, meticulous surgical technique, and anticipate technical challenges, particularly in obese and high parity patients, while future outcomes can be enhanced through larger studies and standardized operative protocols. Thank you.
Thank you very much. I would like to invite Professor Ahmed Akin again for his next talk on retropubic TOT in stress urinary incontinence.
Chairs and dear colleagues, actually, I'm going to talk about transobturator tape, which is the most commonly performed operation throughout the world, and I'm sure you've been doing TOT in your country as well. But to tell the truth, the conventional TOT is the wrong technique. Please quit doing that. So what I'm going to show you is quite easier. A small change in your maneuvers will end up a huge difference, not only regarding the complications, but also the rate of improvement of the stress urinary incontinence. So let's start with a video. Basically, this is retropubic TOT. Now we start with a full thickness incision underneath the urethra. And we are just trying to open up the paraurethral spaces. And I do always use a knife number 11 in order to carry out the incisions, because I just want to be under the pubocervicovaginal fascia. And then I start cutting with a scissors the paraurethral tissues to the depth of the obturator internus muscle. And I just, again, try to open up the space as much as possible. Now, here is the trick. Now, for your operations, I think you do this incision, which is crossing the urethra. In this technique, the middle between the clitoris and the urethra is localized, and a line cross to the pelvic, inguinal part is drawn. So we do our incision in this part. You see, if you cross a line from here to there, you got those incisions. And once those incisions, now just look at the placement of the needle. In conventional TOT, the needle axis is almost parallel to the genital hiatus. But in this technique, as you see, the needle axis is more vertical to the genital hiatus. That is the basic difference. So we start coming from the anterior crista iliaca, or inguinal ligament, it's better to tell like that. But in conventional TOT, you start, your axis is like this. And then the maneuvers are more or less the same, like conventional method. The placement of our fingers on the needle is like that. I press the body of the needle, then feel the edge of the needle on my finger, then start rolling it down and taking out from the incision. Then I will load the mesh onto the stillet, which we use this needle for the TOT operation. And to tell the truth, you can't find this needle anymore because it's not being produced. And I got only one actually. So after loading the mesh onto the stellate, I just do the same movements, the reverse of the same movements as entering into the space. You see, it's a little bit difficult. And now you see exactly the reverse maneuvers which I did while I was entering into the space. And this is the placement of the mesh. And the other side is being placed like this again. It comes from the opposite side right now. The basic issue, we just want to mimic the pubourethral ligament. But in conventional TOT, you only mimic the hammock, not the pubourethral ligament. That's the basic problem of the conventional TOT technique. Then now we are loading the mesh onto the stellate of the needle, and I'll take it to the pubic region or to the obturator region throughout the maneuvers which I did while I was entering into the lodge. And the rest is more or less the same. Tightening is another important issue. When you place the mesh underneath the urethra, you should be sure that the distance between the urethra and mesh should not bigger than 3 millimeters or not lower than 3 millimeters. In both situations, you would end up with problems like inefficient operation or voiding difficulty. And there is another thing that I've been doing. I always cure the pubocervicovaginal fascia onto the mesh, over the mesh, sorry. The basic aim is you should bury the mesh so that the erosion rates will go down further and further. My erosion rates are really is approaching nearly 0% right now by doing this small maneuver. Now, then I'm going to close the incision. That's it. Now, when we look at the technique, it's quite the same of the conventional one, but the basic issue, the entrance point is a little bit lower, and the maneuver of the needle is quite different from the conventional one. And as you see here, this is the one I think you've been doing, and it's known as oblique TOT. But here is the horizontal or the retrooblique TOT. The entrance and the distance are quite different. By doing that, you are more likely mimicking the anatomical pathway of the pubourethral ligament, which is the most important ligament in stress urinary incontinence. This slide is not mine. This slide is from my friend Emmanuel Delorme, and you know he's the inventor of the procedure. And as you see, he says never oblique TOT. It is not me, it's him. He even he was in Istanbul in our last meeting, and I just invited him to tell what he's been thinking on the issue, because I've been telling this to my colleagues in Turkey, but really hardly I have some supporters. You know, people when do something and it becomes a routine for them, it's quite difficult to restrict or to change their way of doing. But if you are on the side of science, or if you would like to do something good to your patient, please completely quit performing conventional one, because you are not doing good, you are harming her. in the longer term, those patients had a lot of problems. And basically, it is the main reason is the mesh is going upwards towards the urogenital triangle. As a matter of that, within time, now they are starting to have different problems, such as frequency, which is a very bad symptom. So, what I'm trying to tell you again, if you do retropubic or horizontal TOT, not only the success, but also the rate of complications will definitely drop down. You see, never oblique TOT. And this is my last slide, and you see the difference between retropubic and the oblique TOT. Oblique TOT does not mimic pubourethral ligament. It only supports the vaginal hammock. So if you want to do a support to the vaginal hammock, you don't need to do, or you don't need to put a mesh. Just cure it. But if you are on the side of science, or if you are on the side of integral theory, you should be performing retropubic TOT, which is quite easy to be done. And this is our journal. I do want you to send your studies to this journal. It is a very good journal for the ones who have been practicing in the light of integral theory, and the publication period is lower than 3 months. Please keep in mind this as well. Thank you very much.
Thank you for a lovely presentation. Next, we will be running a pre-recorded presentation by Dr. Dudley Robinson on overactive bladder syndrome.
Very sorry that I can't be there with you in person. For those of you who don't know me, my name's Dudley Robinson. I'm a consultant urogynecologist and I work here at King's College Hospital in South East London. So overactive bladder is defined by the International Continence Society and the International Urogynecological Association as urinary urgency, usually accompanied by frequency and nocturia, with or without urgency urinary incontinence in the absence of urinary tract infection or any other obvious cause. And it's important to realise that this is a symptomatic diagnosis and not a urodynamic diagnosis. What do we know about overactive bladder? Well, we know it's a common condition. Around 17% of the population, both in Europe and the United States, will complain of symptoms. It's often underdiagnosed and it may be undertreated, with only around a third of patients who complaining of symptoms who actually attend their doctor and are treated appropriately. We also know that it gets more common as we get older, so there's an increase with increasing age, and therefore there's a significant burden in terms of both primary and secondary health care. And of course we know that overactive bladder has a significant effect in terms of quality of life. So this is a study looking at a disease-specific questionnaire, the OABQ questionnaire, and also the short form 36, which is a generic quality of life questionnaire. And as you can see, those patients with overactive bladder dry, but particularly with overactive bladder wet, have a much greater effect on their quality of life as compared to those normal controls. So how do we manage patients with overactive bladder? Well, to illustrate this, I'm going to show you the treatment guidelines and algorithms from the International Consultation on Incontinence, which was published in 2023. And this is now freely downloadable as a PDF from the ICS website. So in terms of looking at the initial management of urinary incontinence, you can see we take a history here in green, so incontinence on physical activity, mixed symptoms and incontinence associated with urgency. In the blue box, we then have a general assessment, importantly a pelvic assessment, screen for infection, and then a measure of post-void residual. And based on that, we can make a subjective, or if you like, a presumed diagnosis of stress urinary incontinence, overactive bladder with incontinence, or perhaps mixed incontinence. And based on this initial clinical assessment, we can then start primary management in terms of lifestyle intervention or perhaps drug therapy. Now, of course, one of the problems with overactive bladder is that there's many different causes of frequency and urgency. And if you look at this slide, there's around 22 different causes of frequency and urgency. And when we make a diagnosis of overactive bladder, what we really need to do is try and exclude these. Sometimes, of course, that may not be possible, and this is where we move on to the more specialised management of urinary incontinence on women. So here again, we take a history, but now in that blue box you can see urodynamics are integral in making our diagnosis, and based on our urodynamic investigations, we then have a diagnosis of urodynamic stress incontinence, detrusor overactivity with or without incontinence, or perhaps mixed urodynamic incontinence. And based on urodynamic investigations, we can then proceed to perhaps the more invasive treatments for overactive bladder syndrome. So this is a urodynamics trace from King's. On the top line you can see the abdominal pressure in black, the middle line the bladder pressure in blue, and the subtracted detrusor pressure at the bottom in red. And you can see, looking at this cystometrogram trace, as the bladder fills we have both systolic and provoked detrusor overactivity, allowing us to make a urodynamic diagnosis. So we can now make a diagnosis of detrusor overactivity, which is a urodynamic observation characterized by involuntary detrusor contractions during the filling phase, which may be spontaneous or provoked. Now, it's important that we make this definition because overactive bladder and detrusor overactivity are not necessarily the same, and certainly the terms are not synonymous. And you can see in terms of women, only around 44% of women with overactive bladder dry have detrusor overactivity, and around 60% with overactive bladder wet. So I know very often we use these terms interchangeably, but I think it's important to remember that overactive bladder is a symptomatic diagnosis, whereas detrusor overactivity is a urodynamic diagnosis. So how do we manage our patients with overactive bladder? And of course we have a spectrum of treatments. So if we start top right, we have lifestyle advice, bladder retraining with pelvic floor exercises. Of course, central in terms of managing overactive bladder is pharmacotherapy. And then we have the more invasive treatments which we may consider using for a refractory overactive bladder. So for the rest of the presentation, I'm going to be showing you the guidelines from the International Consultation on Incontinence, which was published in 2023, and as I said, is now freely downloadable from the ICS website. And in terms of levels of evidence and grades of recommendation, this all fits with the Oxford guidelines, which have already been previously reported. So in terms of lifestyle interventions, there's a grade A recommendation for weight loss in those patients who are overweight, and now only a grade B recommendation for caffeine reduction and fluid reduction for those with a high fluid intake. And the current UK guidelines say that you should drink around 24 mils per kilo per day to be normally hydrated. But remember, that's in a temperate climate in the UK, and maybe it'll be a little bit different in Pakistan. In terms of lifestyle interventions, a grade A recommendation for bladder retraining. This should be considered as first-line therapy for patients with overactive bladder and detrusor overactivity, and a grade B recommendation for pelvic floor muscle training and bladder retraining in those patients with mixed urinary symptoms or overactive bladder symptoms. So after lifestyle interventions, antimuscarinic drugs are still the most common and currently the most widely used drugs for overactive bladder symptoms. And antimuscarinics work by reducing the intraphysical pressure, increasing bladder compliance, raising the threshold for micturition, and also by reducing the number of uninhibited bladder contractions. Now, of course, we're now very fortunate. We have a number of different antimuscarinic drugs on the market. Again, this is from the international consultation, and you can see all of those drugs that you'd consider using for overactive bladder have level 1 evidence with a grade A recommendation. Of course, the one drug on this slide which is slightly different, which is mirabegron, and of course this is a beta-3 agonist drug. So we now have the luxury of having an alternative way of treating detrusor overactivity. So on the left-hand side of this slide, we can see the traditional pathway where we have the antimuscarinic drugs which block the M2 and the M3 receptors, and by doing so block detrusor muscle contractions. Conversely, on the right-hand side, we now have the beta-3 agonist pathway, so mirabegron, which stimulates the beta-3 receptors and by doing so leads to bladder relaxation and hence an improvement in bladder symptoms. So what's the evidence from mirabegron? So this is a study from Vic Kular. So this is a large European study looking at just under 2,000 patients randomized to mirabegron with tolterodine as the active comparator compared to placebo. And you can see with mirabegron there was a significant reduction in terms of incontinence episodes, micturition frequency. But I think it's important to note here that the side effects with mirabegron were much lower than those with tolterodine. So you can see much lower dry mouth with mirabegron and similar rates to placebo. Reassuringly, no cardiovascular side effects. So mirabegron was the first beta-3 agonist on the market. We now have vibegron, which has recently been launched within Europe. So this is a study from David Starskin and colleagues in North America. So this is 1,500 patients randomized to vibegron, again with tolterodine as an active comparator. And you can see a significant decrease in micturition frequency and incontinence episodes with vibegron as compared to tolterodine, and also a reassuring low rate of discontinuation. So now we have these two beta-3 agonists on the market, mirabegron and vibegron. Now, of course, now we have two different types of drug, then we can start thinking about using these drugs in combination. So this is the BESIDE study, which was reported by Marcus Drake in 2015, and this looks at combination therapy with mirabegron and solifenacin. So this was just over 2,000 patients who were either randomized to monotherapy with solifenacin or combination therapy with solifenacin and mirabegron. And as you can see in the combination therapy arm, there was a significantly greater reduction in terms of incontinence episode frequency and micturition frequency as compared to solifenacin monotherapy. Reassuringly, there was no significant increase in terms of complications with regard to dry mouth and constipation, and I think even more importantly, there was no significant effect in terms of blood pressure or heart rate, including QT prolongation. So the findings of the BESIDE study was that combination therapy was superior to 5 milligrams of solifenacin for the primary and key secondary endpoints, whereas combination therapy was non-inferior to solifenacin 10 milligrams for the same endpoint. So I think we now have good evidence that we can use combination therapy in our patients who are perhaps refractory to monotherapy. So what about those patients who are refractory to drug therapy overall? And then, of course, we'd start talking about potentially treatment with botulinum toxin or possibly neuromodulation. So botulinum toxin has been investigated in the EMBARK series of studies, both in Europe and North America. This is a study from Europe with Chris Chappell, and you can see that those patients who had botulinum toxin 100 units had a significantly greater reduction in urgency incontinence episodes as compared to those patients taking placebo. Overall, there was a significant reduction in terms of frequency, urgency and nocturia, with a significant improvement in terms of quality of life. Higher risk of voiding dysfunction in terms of the botulinum toxin group, a greater need for self-catheterization, and also around 30% of patients who have botulinum toxin will subsequently develop lower urinary tract infections. An alternative for those patients who aren't willing or able to self-catheterize would be to consider neuromodulation. And when we think about neuromodulation, we can consider posterior tibial nerve stimulation or potentially sacral neuromodulation. This is a systematic review and meta-analysis of posterior tibial nerve stimulation performed by Claire Burton and colleagues, and this looked at 4 randomized controlled trials, and you can see pooled subjective and objective success rates of around 60%. So certainly patients who have PATNS notice an improvement in terms of their symptoms. The problem is they need to come for 12 once weekly treatments and then monthly treatments thereafter, which is expensive in terms of time and money. An alternative, of course, is sacral neuromodulation. We now have 2 different devices on the market, the traditional neuromodulation device from Medtronic and also the newer Axionics device, which has been launched more recently. So this is a recent study looking at the use of InterStim, which is a Medtronic device. So this was a study of 340 patients followed to 5 years, and all of these patients had refractory overactive bladder. And you can see 5-year success rates in the intention to treat population of around 67% and the per protocol population of around 82%. Overall, there was a significant improvement in quality of life, but as you can see, a significant number of implants failed and a significant number were associated with pain. And you can see here the overall explantation rate at 5 years was around 20%. How does neuromodulation compare to botulinum toxin? So these are the results of the Rosetta trial, which was a prospective 24-month multi-center randomized controlled study looking at sacral neuromodulation versus botulinum toxin. And whilst botulinum toxin tended to have better efficacy at 6 months, at 24 months there was no difference between the 2 groups in terms of resolution of symptoms. Overall, there was a higher satisfaction rate with botulinum toxin, but as you can imagine, there was also a higher risk of urinary tract infections and self-catheterization. In terms of those patients who had sacral neuromodulation, you can see revision rates of around 3% and explantation rates of just under 10%. And we now have the newer device from Axionics. So this is a rechargeable sacral neuromodulation device. This is a much smaller and shorter term study of around 130 patients. And these patients were followed up at 6 months. And as you can see, 90% continued to respond to treatment. And there was a significant reduction in urgency incontinence episodes with a meaningful improvement in terms of quality of life. And this study was also associated with a high satisfaction rate. So in conclusion, how should we manage our patients with overactive bladder? Well, I think certainly conservative therapy is indicated as primary treatment. Antimuscarinic drugs at the moment still remain the most commonly used drugs, and remember that you can tailor your drug therapy to a particular patient. However, very often antimuscarinic therapy is limited by tolerability and efficacy, and this may have a significant effect in terms of compliance and persistence. As an alternative to antimuscarinic drugs now, we have the beta-3 agonist drugs, and remember we can now combine these together in combination therapy, which hopefully will lead to a greater improvement. Finally, in our postmenopausal women, don't forget to add in some vaginal estrogen therapy, and there's good evidence to show that this works synergistically with oral drug therapy. And for those patients who have refractory symptoms which haven't responded to pharmacotherapy, then we have options now of botulinum toxin, posterior tibial nerve stimulation, and of course sacral neuromodulation. And I think it's important to consider all of these before perhaps offering reconstructive surgery. So I'll finish there with a picture of our team from King's with Professor Cardozo when she was still with us, and I'll be delighted to answer any of your questions in the Q&A session at the end of this section of the conference. Thank you very much for your attention.
Next, to present an audit on 3rd and 4th degree perineal tear at Princess Alexandra Hospital, I would like to invite our speaker, Dr. Nabila Iram, a consultant obstetrician and gynecologist working at Princess Alexandra Hospital, NHS Trust, UK.
Good morning, everyone. Thank you very much, Professor Nazli, for arranging such a wonderful session and conference. Initially, it seemed like it would not be possible to come to Pakistan, but I feel I'm lucky enough. I was able to reach in time and present my research work. And thank you, whole team, tirelessly. I know, like, we were texting like quite late at night, sending emails quite late, and your team was really, really very responsive and very helpful. My topic is this audit on 3rd and 4th degree perineal tears, and I think after all the discussion we have so far, I think prevention and proper diagnosis and repair of these tears in childbearing age is really important to avoid all of these urinary and fecal incontinence and related problems later in the life. I'm really thankful to my team who worked in data collection, prepared the presentation, and worked hard to prepare all the slides and presentation. Regarding the background of the 3rd and 4th degree perineal tear, we all know obstetric anal sphincter injuries, they encompass basically 3rd and 4th degree tears. And there are significant complications of vaginal delivery, and they have a long-term association with the pelvic floor morbidity. National target incidence, we aim around 3% of the vaginal deliveries, and I will discuss our data, which was slightly above that, and but our previous years we were well below the national average. Rationale of this study was to see the compliance with the RCOG guideline, because the guideline recommends systematic examination, appropriate repair, and comprehensive post-operative care plan for these patients. And local audit enables comparison against the national benchmark and identifies area of improvement. And this 3rd and 4th degree tear is one of the part of the national audit that every trust does annually. Objective of this audit was to evaluate the incidence of 3rd and 4th degree tears at Princess Alexandra Hospital during 2024, and to assess the compliance with the RCOG documentation and management standards, and identify the risk factor associated with obstetric anal sphincter injuries. As we all know, Asian ethnicity, we do see more or less like they are about 1/3 of the patients who belong to the South Asian areas, and their tissues are somehow more prone to sustain these tears. Nulliparity, we all know, and it's even our study has shown that it is the highest association with the 3rd and 4th degree tears. Having a large for gestational age babies, we can explain like the way this can damage the pelvic floor of the pregnant woman. Shoulder dystocia, occipito-posterior positions, prolonged second stage of labor, or precipitate or rapid second stage of labor, previous obstetric anal sphincter injuries, instrumental delivery, these are all well-known associated risk factors. And we should be aware of all these because these are the kind of predictors, and we need to be vigilant while delivering these patients. It was a retrospective audit of all obstetric anal sphincter injuries, of all the cases which were done at Princess Alexandra Hospital, and the study duration was from January 2024 to December 2024. Can we please, Professor Zaman, sorry for the interruption, just for the sake of the study duration was from January 2024 to December 2024, and data was collected from all the electronic patient record. And parameters assessed for incidence rates were compared against the national target, risk factor evaluation, and association with the parity and mode of delivery, documentation like systematic examination before suturing, what type of analgesia was used, what kind of suture material was used, repair techniques like it was end-to-end or overlap, and grade of the operating surgeon, post-operative management advice, provision, and follow-up arrangements, and training status of all the doctors performing the repairs. This is the performa we are using at our trust for the data collection, and if you can, I think the font is not too small, you can see it's a very comprehensive performa. It stays from all, apart from the demographic, about all the documentation about the tear, what type of tear, and then at the end you can see whether these patients, they were given information leaflets, follow-up was arranged, whether they were seen by one of the pelvic floor midwife, and whether they were given antibiotics, analgesia, laxatives, and a training status of the doctors, and whether these patients were debriefed after the delivery or not. This is the performer like with every third and fourth degree tear, because all of these tears, they are DATEX. DATEX is a basically incident reporting system, and from where these cases are picked up, and then all the data is retrieved through these pre-filled performers. Results of our audit, we had about 1946 vaginal births, and out of these 1589 were spontaneous deliveries and 357 were instrumental deliveries. And 63 women sustained obstetric anal sphincter injuries, and making an incidence of around 3.24%. And a national target, as I already said, it should be less than 3%, is slightly above that. 2 cases, they involve rectal buttonhole tears. And this is the further split up of the cases. Like you can see, like the primate, as we all know, that is one of the strong risk factor associated with the assisted vaginal birth. There were 21 patients which is the highest number out of all of the remaining criteria. And this diagram shows the association with the parity that proves that is associated with the primiparous woman. And this is the categorization as according to the types of the tear, and we can see highest number of the patients, there were 3A, followed by 3B and 3C, and there were 3 cases of 4 degree. This is as I mentioned, this is the national audit, and every trust has to do it annually. And that is, you can see incidence of the obstetric anal sphincter injuries, that is over the years. And it ranges from 2020 to 2024. You can see initially we were quite below the target, but the 2024 was like we just crossed the target by 0.2. And this graph shows the role of the manual perineal protection and the warm compression. Our previous audit showed that we were not following the recommendations of providing perineal protection. You can see, like in 2023, there were very few patients who were provided that, but with the recent audit, we can see that is a significant uptake of these by the midwives. And this table compares the standard of practice, like this is like whether these patients, they have adequate follow-up, there was systematic documentation of the findings, like vaginal tears, perineal tears, or any sphincter tears. And then properly, they have the proper follow-up in place, and whether a debrief was done. And you can see from 2020 to 2024, we, in all the areas, we have significantly improved, and we have met our targets. In conclusion, obstetric anal sphincter incidence, as we said, it was slightly above the national target despite 100% compliance with the management standard. Primiparous women undergoing instrumental delivery, they represent the highest risk group, making about 34.9%. Documentation, repair technique, and post-operative care all met RCOG standards. Therefore, recommendations were to increase the adoption of the manual perineal protection techniques during the second stage, promote warm compression application as an evidence-based intrapartum intervention, and develop targeted risk reduction strategies for primaries and instrumental deliveries. And reducing the obstetric anal sphincter injuries will not only reduce the long-term maternal morbidity and improve the quality of care, but it also, I think, will improve the patient care overall. Thank you very much, everyone, for patient listening. Thank you. I love my classes, yes.
Thank you very much. Next, we have a pre-recorded presentation by Dr. Sadia Shaukat, a consultant gynecologist from Hyderabad, Sindh, on pelvic organ prolapse in pregnancy.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Sadia Shaukat, consultant gynecology and obstetrics at Hyderabad, Sindh, Pakistan. Dear colleagues, distinguished faculty and fellows, it is an honor for me to present at IRC RCOG Summit, and I'm extremely thankful for the opportunity. My paper is on pelvic organ prolapse in pregnancy. We all know that this is a very rare clinical presentation occurring 1 in 10,000 to 15,000 deliveries or 224 cases per 1 lakh pregnancies. When we see the literature has isolated case reports and case series. The last systematic review was published 10 years back on the topic. So I decided to write a systematic review, an updated review to guide on clinical presentations, antepartum management, maternal and neonatal outcomes, and on deciding about the mode of deliveries. So what I did, I followed Prisma 2020 guideline. I registered it on Prospero. This is the ID. This is the Prisma flowchart. I searched on 5 electronic databases: PubMed, Science Direct, Google Scholar, Cochrane Library, MDPI, and on other sources of ResearchGate as well. My initial search returned 12,900 papers. The keywords used were with Boolean operators were pelvic organ prolapse or uterine prolapse or prosidentia and pregnancy or gestation or antepartum. On these 12,900 papers, I applied the automation filters that made this ineligible around 8,000 papers. The filters were like paper published in the last 10 years or the papers in the English language, consisting of the women of the reproductive age. Then I was left with 4,200 papers. I read the title and the abstract of all those papers, and out of these, I was left with 90 research articles. Out of them, 4 full text was not retrieved. Out of these 86 papers, I assessed on the eligibility. For the eligibility, I used Johanna Berg Institute checklist scoring system that has 8 questions for case reports and 2 more questions for the case series. 4 papers were marked as poor quality. One was in the French language. One case report was of a conference. The information was not complete. 4 papers were on editorials or opinions. So I was left with 44 studies. In 44 studies, 37 were the case reports and 7 were case series. 30 were qualified as high quality papers, 5 good quality, and 9 were the fair quality studies. So, total there were 59 individual cases from 19 countries. 19 countries that include India, Turkey, Ethiopia, China, USA, Australia, Nigeria, Morocco, Japan. The inclusion criteria was reproductive age women of 18 to 45 years, pregnancy of any parity or gestational age, pelvic organ prolapse regardless of stage or type, studies describing any aspect of antepartum management, conservative measures, pessary use, surgical intervention, maternal and neonatal outcome. We excluded the studies that included editorials, reviews, studies focusing on pelvic organ prolapse outside the pregnancy or in the postpartum, or conference abstracts were excluded as well, as they were lacking the full case details, or the low quality reports were excluded as well. Now, what were the results? The population was young, 21 to 43 years age. 54 women were multiparous, and they usually presented in the higher order parity, that is gravida 4 or more, and 59 cases were there. Out of the 59 cases, 50 cases presented with stage 3 or stage 4 prolapse, and they were presenting mostly to the clinics in the third trimester. There is no surprise that the most common symptom the woman presented was visible vaginal mass. Now, how they the obstetricians or the urogynecologists managed the cases that uh, that the conservative management option was used bed rest and Trendelenburg position. Silicone pessary was used in 18 of the cases, and in acute setting, manual reduction method employed. 4 cases used surgical intervention in pregnancy, but if we see that out of the 59 cases, 4 cases used surgical intervention, that means that 55 of the cases that obstetricians or the urogynecologists successfully maintained the pregnancies with the good outcome on non-invasive conservative measures of bed rest, pessary, and Trendelenburg position. 19 cases were reported with preterm birth, that is the higher ratio than the general population, and this indicates that antenatal good surveillance is needed with timely corticosteroids. When we talk about the mode of the delivery, the vaginal delivery was achievable in most of the cases. That means that cesarean section is not an automatic indication of a pregnancy with pelvic organ prolapse, but cesarean section was done only where the prolapse was so huge or it was causing an obstruction, that is due to the obstructed labor or cervical dystocia or cervical edema. 30 women successfully delivered vaginally and one ended in total vaginal hysterectomy. The neonatal outcome is encouraging. 49 live healthy births and 5 prenatal births were reported. The recommendations are antenatally conservative management with bed rest, Trendelenburg positioning, manual reduction in acute setting, use of silicone ring pessary in the second and third trimester with counseling of the woman and making sure that the woman is on follow-up. When we talk about delivery, individualizing delivery planning, we need to the monitor the women. These women may go into the preterm birth, so timely corticosteroid administration. We need to aim for the vaginal delivery. Cesarean section is only when there is an irreducible prolapse, severe edema, dystocia, obstruction, or fetal distress. Avoid the fundal pressure during delivery, and the multidisciplinary care is needed where there is a complex anatomy or severe complications are anticipated. Counsel women on postpartum recovery, long-term surgical planning, and pelvic floor therapy. So, the pelvic organ prolapse during pregnancy is although an uncommon, but when it is presenting, this is an high risk pregnancy and they usually present with high stage prolapse. It is associated with the risk of preterm birth and cesarean delivery. Primary approach should be pessary insertion with advice on bed rest, and vaginal delivery is generally achievable in most cases. Thank you.
Thank you. Next, we have our clinical fellow urogynecology in Shalimar Hospital, Dr. Hijab Aziz, to present a comparison between anterior colporrhaphy native tissue repair for pelvic organ prolapse.
Assalamu alaikum. I'm Dr. Hijab Aziz, fellow of Urogyne from Shalimar Hospital, Lahore. And the topic for my presentation today is a comparative analysis of conventional anterior colporrhaphy with native tissue repair for pelvic organ prolapse. So starting with the background of the problem, why do we need to study the topic? The pelvic organ prolapse is a prevalent condition in women affecting 30 to 40% of all women, clinically impacting their life in the form of urinary, bowel, sexual dysfunction, and reduced quality of life. The management options include conservative management in the form of pelvic floor muscle therapy, pes replacement, and definitive surgeries. The most common pelvic organ prolapse is the anterior vaginal wall prolapse, and the most commonly performed surgery hence is the anterior repair, which can be done in the conventional method known as the conventional anterior colporrhaphy and the native tissue repair. So briefly describing the difference between the two. The anterior colporrhaphy is a specific anterior wall repair including the anterior compartment only. It is a pubocervical facial plication and no mesh is used. It is a standard method for correction of cystocele, and according to the literature search, the recurrence rate is comparatively higher. Whereas the native tissue repair is a broad category of repairs. It includes the use of fascia, the patient's own fascia and ligament to strengthen the pelvic floor, and hence the scope is limited not only to the one compartment, it overall improves the pelvic floor muscle strength. No mesh is used in this. It is a versatile and customized approach. It restores the overall support and potentially lower rate of recurrence. The aim of the study was to compare the efficacy, the anatomical outcomes, and the patient satisfaction rate and compare both the groups between conventional anterior colporrhaphy and the native tissue repair. So the hypothesis to be tested was a native tissue repair for anterior prolapse is more effective than anterior colporrhaphy based on anatomical and functional outcomes. It was an observational study conducted at Shalimar Hospital, Tertiary Urogynecological Center from January 2023 to September 2025. A convenience sampling was done with 20 patients in each arm. There were two groups, the population undergoing anterior colporrhaphy and the group 2, the population undergoing native tissue repair. SPSS statistical software was utilized. The qualitative data was analyzed using the chi-square test, and the quantitative parametric data was analyzed using students' t-tests, and the parametric data was analyzed using likelihood ratio test. Now, the inclusion versus exclusion criteria. The inclusion criteria included the adult women who were greater than 20 years of age, the cystocele have grade 2 or more according to the POPQ classification, the patient had no plan to get pregnant in the coming 12 months, and the informed consent was taken. The exclusion criteria included the patients who had to go other anti-incontinence procedures as well, or had a previous vaginal surgery, or were immunocompromised, like in the form of uncontrolled diabetes, or they had any symptom of urinary tract infection which was chronic in nature. The pre-op assessment was done by taking a detailed history in the form of biodata, chief complaints, history of presenting illness, gynecological history, obstetrical history, medical history, surgical history, family history, with special focus on urogynecological problems. The examination was done in the form of general physical examination, the abdominal examination, and the pelvic examination. The pelvic examination included the bimanual examination, the cuff test, and the POPQ classification for checking the level of prolapse. As we know, the stage 0 was known as a well-supported organs. Stage 1, when the distal part of the prolapse was greater than 1 centimeter above the level of hymen. 2, when it was 1 centimeter above or 1 centimeter below the level of hymen. 3, greater than 1 centimeter below the hymen. And 4, when it was complete eversion. The pelvic floor muscle strength was checked using a vaginal examination and graded. Grade 0 meant absent strength, 1 dedicated weak, 2 with moderate, and 3 with good pelvic floor muscle strength. Post-operatively, patients were prescribed medications, contraceptive advice. They were counseled regarding when to return to work activities and presumption of sexual intercourse. Pelvic floor exercises were explained. Post-op follow-up was done at 6 weeks, 4 months, 6 months, and then at 1 year. And the post-op success was defined as a POPQ score of 0 or 1, and in the form of improved urinary vaginal symptoms and quality of life. The study instruments used to assess the outcomes were in the form of urinary incontinence short form, which showed the impact of urinary incontinence on the quality of life. Scores range from 0 to 21. The final score of 0 meant no symptoms of urinary incontinence, and greater than 3 or equal to 3 showed presence of urinary incontinence. The second tool was overactive bladder questionnaire, and the scores ranged from 0 to 48, with the final score of 0 showing no symptoms of overactive bladder, and greater than equal to 1 showed symptoms of overactive bladder. The vaginal symptom scoring was done, ranging from 0 to 53, with score of 0 showing no vaginal symptoms, and vaginal score of greater than equal to 1 showed the presence of vaginal symptoms. The quality of life was also assessed by the questionnaire, and the range was from 0 to 10, and the higher the score, the worse was the quality of life. So looking at the results, the clinical characters of both the group showed the p-value was greater than 0.05. That meant that clinical characteristics of both the groups were same. There was no discrepancy like the age, parity, BMI, smoking, menopause. All the data that was collected, the patients that were included, the data there was no bias in the selection of population. The pelvic floor muscle strength, again, the p-value was greater than 0.05 preoperatively. And the POPQ staging, again, was greater than 0.05. That means that the data was not biased preoperatively. And the comparison of post-operative data in both the groups showed that, as we can see, that voiding difficulty was improved in 60% of the patients who had undergone anterior colporrhea, while in native tissue repair, the result was 93%, giving us a p-value of less than 0.05, which means that it was significant and the native tissue repair had a better outcome in resolving the voiding difficulties. However, the value was not significant for stress incontinence. The vaginal bulge or pressure or the vaginal symptoms, the p-value was again significant, less than 0.05, which meant that the symptoms resolved better with the native tissue repair. The bar chart shows the quality of life and the vaginal scores in anterior colporrhea and the native tissue repairs, and the negative impact on quality of life was greater with the anterior colporrhea as compared to the native tissue repairs. Likewise was the case with vaginal symptoms. The POPQ classification postoperatively showed that although cumulatively both the groups had undergone better anatomical outcomes, but in comparison to both, native tissue repair had comparatively better outcomes anatomically as compared to anterior colporrhea. And the recurrence rate was also lower, that was less than 0.05. The patient satisfaction percentage showed that 99% of the patients who had undergone native tissue repair was satisfied, and while in the anterior colporrhea, the score was 60%. So the conclusion of the study, it showed that although both anterior colporrhea and native tissue repair had overall good anatomical outcomes, but the native tissue trapezoid repair was associated with better anatomical outcomes and greater patient satisfaction rate. However, we advise that treatment must be individualized on the basis of patient's preference and surgeon's experience. Longer follow-ups with randomized controlled trials are recommended from research point of view. Thank you.
Thank you, Dr. Hijab. A kind reminder to keep your mobile phones on silent and use the hind door during the sessions. Before we move on to tea break, I would like to invite Professor Farooq Zaman to share his invaluable insights with us.
Professor Nazli Hameed, Professor Ahmad, Brigadier Nadra Sultana, fellow panelists, friends, colleagues. It's been a pleasure being part of this session, attending it. And I was thinking that if it weren't a little too late in the day for me, I would have joined training in urogynecology. And maybe would have been a fellow resident of Melissa, right? But you see, there have been 12 presentations. 3 were in absentia, but and the 9 were in person. And I must compliment, first of all, Nazli for managing this conference so well. And it's a pity, actually, that for this session, which has been so interesting, we had not adequate number of or amount of audience. It could have been much better than this. But I'm sure that, like me, most of you must have enjoyed, thoroughly enjoyed, and got inspired by all the presentations. I would particularly like to thank Professor Ahmed for being here and for making 3 presentations out of the 12 here on various aspects of urogynecology, which is very important. And the 2 presentations made by Professor Dudley Robinson, they were also, although they were very elaborate, rather lengthy presentations, they were very nice, very informative. Second point that I would like to make is that if we really want to manage things properly, we can. 10:55 was the time that this session ended, and actually it ended at 10:55. 12 presentations, 3 online, 9 in person, and still we managed absolutely to the minute. That's great achievement, and nobody was interrupted, nobody had to run through them, but it was achieved in such a nice fashion. So all in all, it has been a great pleasure, all the presentations starting, and particularly I'd like to congratulate our junior colleagues. They have, from Abtabad, Professor Rokeya's trainee, her presentation of course was very good, but one of her trainees presented, and Dr. Baloch here, your presentation was the second one, that too was very good. So all of them, they presented their original work, which is so good to have, and then they made such nice presentations. It has been really a very pleasant and very nice experience. Thank you very much all.
Now we'll move on towards a tea break. We will be back here at 11:25 a.m. and the expert panelists are again requested to take the seat on the stage after the session starts again. And it's tea break now. I think we should all go.
Yes. Go for the tea.
Yes.
Okay.